First speaker, we are running out of time, so we have requested our speakers to stick to 15 minutes each. So over to Dr. Sunil.
Thank you, Dr. Kalra and Dr. Harish, for those kind words. The 8th of September 2015 is a tragic day in the history of medical health care in India. This was the day when 8-year-old Avinash Raut knocked at the doors of 4 big hospitals in a major city in our country. Treatment was denied. He had a simple problem like dengue fever, and he died of hemorrhagic shock and DIC. In the wake of that sorrow, his parents committed suicide by jumping off the 7th floor of a building. This is healthcare, an anecdotal episode, does not happen every day, but it symbolizes the problem of affordability. Those are the parents who came, sought help, but could not find. Somewhere else in India, in other states, the Bimaru states, it is true that many small hospitals manage with one pair of surgical gowns that are recycled even for repeated cases. Somewhere else in India, I am told that one packet of gloves are available for the entire day and they have to recycle that. It's also true that in other parts where facilities are even less, they have to manage with one basin of boiled water because they don't have a way to get more, and they wash their hands and their instruments in preparation for the next case. India is a complex country where we have the rich and the poor, where we have private hospitals and public hospitals that is back of beyond, where affordability is a major problem. So I'd like to present to you a perspective from a large institution which is in the hinterland of India, CMC Vellore, where affordability versus quality is a constant problem, a daily problem which we have to fight. There is no doubt that quality has come to stay in our country, and we must acknowledge the service that has been provided by NABL and NABH to make us physicians and healthcare stakeholders conscious of the movement of quality. This is a story which is true. A farmer consumed pesticide because of poverty. He was treated in a hospital for 2 months in an ICU, and we slapped him a bill of 1,64,000. He survived. He looked at the bill and said, I wanted to commit suicide because I had no money, not even 1/10 of that. Can I borrow rupees 60 from you to consume another 10 ml of the same poison? This is the truth of the healthcare status of India. Healthcare costs, as per the government's own statement, is the leading cause of poverty in our country. I want to listen to this again. Healthcare costs in our country is the leading cause of poverty. What an irony, what a paradox. GDP of 1.03 is one of the lowest in the world in a country which is boasting of being economically forward. 60% of healthcare expenditure is out of pocket. The insurance penetration is just about 10%. Figures vary from journal to journal. Indian healthcare has a long way to go in bringing social equity to the large population of our country. India has done well in having changed IMR and MMR to closer to world acceptable levels. We have survived the days of famine, where we were called the miserable 1800s, where this was the scene in villages and the hinterland of India. The systems which support affordability in some small way are divided into these 4. Public hospitals, where care is supposed to be free, but as you and I know, it is underpowered. No manpower, lack of facilities, lack of motivation. The state-sponsored schemes, which help to a great extent, is again free, but limited in its scope of coverage. Insurance, where co-pay is a standard mechanism, has high premium, which does not cater to more than 80% of our population. And fee-for-service, which is almost completely insurance supported, is only available to the rich and the famous and is a completely urban phenomenon. There are different models of affordable healthcare. One is the cross-subsidy principle, which Harish alluded to, where you charge premium rates from those who can afford from insurance, and you cross-subsidize the poor, symbolized in the practice in Christian Medical College, Vellore, and the Aravind Eye Care System. The practice of economy of scale, where you keep margins low on services, but make profits on an economy of scale principle, high volume turnover, which you then use to, not to pay high salaries to your doctors, but to cross-subsidize those who don't even have a meal in between the treatment schedules, shown in CMC Vellore and Narayana Hridayalaya. The public-private partnership model, which is in evolution, and I hope that this will bring in a lot of money for subsidized care. Charitable trusts, which on the basis of altruism and philanthropy, contribute significantly, but it's just a drop in the ocean. And the potential of corporate social resources, which is a huge amount of money locked in, unused, with no clarity on which way it should go, is something that we can tap for purposes of philanthropy. There was an article in Harvard Business Review written by two Indians on cost comparisons in the US versus Indian hospitals. It was a very laudable article which talked about the innovative ways with which Indian healthcare made significant difference. The strategies were as follows: the hub and spoke model of asset utility, and I think Columbia Asia and several other networks do this very well. Customized innovations like splicing of cornea done by the Aravind Eye Hospital, and various other techniques that have been referred to. The cost of labor, which is kept optimum by inspiring doctors and health workers to look beyond salaries as the only reason they are in healthcare, to make sure that quality of life and value additions contribute to the overall joy of being a doctor. Asserting frugality in practice, and I think this is something that we have to learn from our own experimentation, and of course, volume-based economy. The components of healthcare which are responsible for high costs and also tools which can be fiddled around to keep it affordable are as follows. One is infrastructure, the second is manpower, consumables, and systems such as information and equipment technology. Let me talk about manpower. First of all, it's important to get good skill and expertise, not just enough to have brilliant people who are skilled, but they should also be fired with a passion and a mission to be service providers, not businessmen. I think the problem with Indian healthcare today is that it's packed with people whose sole intention to become a doctor or a healthcare worker is how do I make quick money. Multitasking, which has been alluded to in the Harvard Business Review report. Task shifting, which has also been alluded to, where a doctor begins to do high quality work and hand over the doable acts to nurses and physiotherapists and physician assistants, freeing his premium time to give his quality care to more patients. And of course, the playing around with automation and outsourcing as a way to reduce the total financial liability of your healthcare setup. Reducing extravagance. There is surely a lot of extravagance in medical practice. The concept of reduce the need to do something. Reuse as many times with strict quality control. Recycle with safety norms. And rethink, do you really need your patient to have that treatment, that procedure will significantly bring down healthcare costs. And these are the 4 principles that we use in CMC Vellore. We have been very quick to adopt Western extravagance. The difference is the state supports healthcare. There is social security and federal funding, not in India where more than 60% of the cost is out of pocket. I trained for 3 years in Adelaide when I did my interventional fellowship. And right from the beginning, in that 3-year period, I personally picked out 43 stents and pacemakers from the dustbin, from the hospital bin, which I cleaned and brought back to my own institution illegally. I thought it was a colossal waste of equipment. Change of scrubs. Do we have to change scrubs in between every hour? Do we have to use gloves at random for no rhyme or reason? Do we keep on changing shoe over small things? It costs just 10 rupees. But if you multiply that, you will see the amount of colossal waste that we practice. Reusing of candles, catches, consumables is again something that we have learnt from the Western extravagance and needs to be reviewed. Hand scrubs. I don't know whether we know that these hand scrubs which we use is 16 times more costly than the standard products that we use. Today, it's being questioned on whether it really offers the kind of protection that was claimed by the people who manufactured them. There's a lot of wastage in drugs. One each, just in case principle by private practitioners. I don't know the diagnosis, so I will give one antibiotic, one antihistamine, one tonic, one vitamin, and one painkiller. It covers everything. Is a practice you and I will agree. The myropenia, as described by one of my colleagues, everybody who goes into ICU gets meropenem because you don't want to take a chance. Is it needed? Does it make healthcare unaffordable? Is a question I will leave with you. Every patient gets a vitamin, sometimes more than one. There's B complex and B cosules given together. There's a vitamin C that comes on board. There's a power capsule that comes on board, especially in general practice. The brand mania that we see, is Plavix needed for 3 years? I'm not too sure. I think there are good Indian products that will do the job. Ranitidine, every 5th person has ranitidine for life. Oxygen is just like an open tap in ICUs. Oxygen is a very expensive drug.
Doc, 5 minutes more.
The statin scam, which you have been reading about, statins are no longer the magic pills. Read the internet, cardiac CT, all the other things that have been alluded to. I think I will skip, but there are also similar things, extravagance in systems, in IT-based solutions, air conditioning, and quality parameters. Evidence for evidence. Evidence is now being questioned on a lot of our practices that have come to stay. These are some of the principles that we have been practicing to do this fight to keep the cost down. And I think I will stop here without going further into this by saying that in the issues of infrastructure creation, manpower recruitment, the use of information technology, and our systems, a philosophy of great austerity has to be practiced to make sure that what we are packaging as quality healthcare is also quality healthcare for the man who does not have more than 60 rupees a day as his earning capacity. Is that possible? How do we trade this off as quality? As quality is something that we need to brainstorm. Thank you.
Questions we will take up after both the speakers have shared their views. Now I request Dr. Anupam Sibbal to share his views.